So Randy Oostra is the President and Chief Executive Officer of ProMedica, a not-for-profit, mission-based, integrated health and well-being organization headquartered in Toledo, Ohio, and serving communities in 30 states. Randy has 40 years of healthcare and management expertise and is regarded as one of the nation's top leaders in healthcare. He has a strong commitment to the healthcare industry and community and is here today to talk about working within hospitals and communities to impact health outcomes. So please join me in welcoming Randy. Thank you.
Great. Good. Young man sitting in bed, looking at the calendar, nothing on the calendar, perfect Saturday. Finishes his first cup of coffee, rolls out of bed, heads back to the kitchen to get another cup of coffee. As he walks back in, his wife is standing in the door of the bathroom and she says, "Honey, come here, I want to show you something." On the counter is a positive pregnancy screen. And very excited, expecting the birth of their first child. So again, you can imagine, they get back in bed, they talk about this life change, what it means, having a child, names, quitting jobs, telling parents, do we have the right size house? What do we do? What does this mean in our lives? So Monday comes around, they make an appointment with the obstetrician. They were able to get in that week, so they both take off work, excitedly go to see the OB. They get there, of course, the staff gives them 32 pages to fill out, some facts poorly but badly. They fill them all out, they put all the forms together, they give them to the receptionist, they're brought back. They do all the type of things that you would expect. They do weight, they do history, they do an ultrasound, they do blood pressure, they get all the information together. And one of the clinical team is there talking to them, putting everything together, and she's looking over the information, and suddenly she goes silent. And the couple very quickly picked up on the silence, and all the clinical person said was, "The doctor will be in shortly." So they sat there quietly, looked at one another, it's like they knew something was up. Physician walks in the room, introduces herself, pulls up a chair, starts to look at the information, and says, "I have some real concerns. I've been looking over your information, and I'm very concerned about your diagnosis." And the couple just get in stunned silence, looking at the doctors like, "What is this?" And the doctor says, "Well, you're a 43604. And the couple look at her and say, 43604? And they go, "That's our zip code." And the doctor says, "Exactly." So, fictitious story, but maybe not. So in the United States of America, depending on where you live, probably determines your life. And so whether you look at life expectancy, and you probably have seen these statistics, in New Orleans, you can literally be blocks, if not a half a mile away, and have a 25-year difference in life expectancy. 25 years. And you begin to look at Chicago, Baltimore, Vegas, Washington, D.C. I don't know if you saw the article lately. There's a community in Oklahoma, the average life expectancy, is 57 years old. So you begin to look at that, and you start to wonder, how in the heck does that happen? How do we have 57-year life expectancy, given all the modern opportunities we have in medicine and social conditions in life? And interesting enough, we were in the middle of the pack not that long ago. We had the same life expectancy as many of the countries that we would compare to. And what the heck happened over the last couple decades? And the bottom line issue for this is the social determinants of health. It's social economic status. And when you begin to look at where we pivoted from the other European countries, is really the issue. And as you two said, where you live shouldn't decide whether you live or die. And sadly, in the United States, your zip code, or some people would call it your ZNA, has more to do than the $3 trillion we spend in healthcare. And that really is kind of the bottom line message of the social determinants. So if you went to a healthcare group and you looked at this slide and the information on this slide, and you showed somebody that you'd have all these hospitals, and you have an insurance plan, and you have doctors, and you work in a lot of states, and you have a lot of money, and you have bond ratings, and you build nice buildings, people would say, "Wow, you are doing a great job." So then you go to another group and you say, "Look at this community. The health aspects of these community, 99 of the top 100 cities in the United States, you're 99th. You have problems in obesity and mental health, homelessness, poverty, food insecurity." And you would say, "Wow, that community has a lot of problems. And you know the punchline, it's the same community. This actually is Toledo, Ohio, where we're from. And the issue here is this is kind of in the American healthcare story. And again, some of you are healthcare people, and the things that we're going to talk about today are things you know. But I want to kind of go through our logic trail over the last decade of how we became so passionate about this social determinant. So Jim Collins wrote a great book, Good to Great, which is a pretty good book. He wrote a better book, Good to Great in the Social Sectors. How many of you read Good to Great in the Social Sectors? You ought to read it and give it to every board member. So in that book, it took him a year to write Good to Great. Took him 3 years to write Good to Great in Social Sectors. It's 50 pages. It's literally this thick. And what he says in there, he doesn't say exactly like this. I was wrong. Good to Great was wrong. It's not how much money you make. It's how you make an impact relative to your resources. And that is true in life. I don't care, just think about it personally. Everyone in this room has different resources. You do. Every organization has different resources. Communities have different resources. But collectively, if you're going to make an impact, as an individual, as an organization, as a community, it's that idea of collective impact. Social return on investment is what we're talking about. You read a lot about it. And really, it's just how do we make these impacts, and especially when we think about the issues in healthcare. So this is an interesting slide from Success. So if you went to Ohio or Michigan, where we're from, within a couple hours, we have the Cleveland Clinic, we have Ohio State, we have Henry Ford, we have Beaumont, we have the University of Michigan, ProMedica, we have one of the Mercies. You just go down the list, Ohio Health, Premier, Parkview, names you would know. And so you look at those and people would say, wow, you have great health care. We have some of the best children's hospitals in the country, Nationwide Children's, Cincinnati Children's, Rainbow Children's, Akron Children's. And yet in Ohio, we are 49th for infant mortality for African-American babies. 49th. So we have all this great health care. Cleveland Clinic advertises across the world as the greatest health care, one of the greatest health care systems. And yet you look at all the things on the right and you say, wow, look at all that health care. And then you look at the statistics for Ohio and the statistics for what we do, and you ask, well, does that really make sense? And yet I go back to if I had a bunch of rating agencies here, they would tell us how good we are in a lot of ways. But it's that whole issue. And so we know this drill, and you all know this, whether it's life expectancy, whether it's cost, whether it's preventable deaths, whether you look at the issues we have in life. We know that we have issues. And what's interesting, it's one thing, $3 trillion, 17.8% of the gross domestic product in the United States. We'll talk about that in a minute. And it's going to go up. And oh, by the way, when you begin to look at it, the darker colors are better, the lighter colors are worse. And so when you look at America versus the other OECD countries, you would see, okay, it's one thing if we're getting great outcomes for our $3 trillion, but we're not. And so, and I always get in trouble when I say this, so we talk about value-based care with a broken system, which doesn't make really a lot of sense if you think about it. We're talking about value-based care in a broken system. So how did we get here? And again, you can go back and trace healthcare in the United States. If you've read, there's some great books about history of the United States. Paul Starr's book, The Social Transformation of American Medicine, talked about how healthcare evolved in the United States. Very specific reasons. And a lot of times people want to blame healthcare. No, we created this as a country. We passed the Hill-Burton Act. We put people to work after World War II. We built 4,000 50-bed hospitals in the United States. 4,000. We didn't exactly, that's how many beds we built. And it was perfect because World War II, all these great advances in medicine. So we built all this stuff. We put people back to work. We created better health care. They became these major institutions in our country, the three defining institutions of a lot of communities, churches, hospitals, and schools. And yet, over a period of time, and then in 1965, we did the right thing with Medicare and Medicaid. How could you argue with that? But along the way, we never put any cost controls. Fee for service. When you pay somebody to do something, what do? They do it. And they do a lot of it. And so that's exactly what happened in healthcare. And so now you kind of look where we are today, 17, 18% of the GDP. You start to read about 30 to 37% in a couple decades of our GDP. And so something has to change. And I think what's concerning nationally is, so what makes us think anything is going to change? And then I think you kind of come back to healthcare being a local phenomenon and for the folks in this room. And so what it comes back to is what are you going to do in your local community while we as a nation figure it out? So the impact of healthcare, this is the hard part. This is the things that when we talk about things that we always have to keep in front of us, it's the impact on people. Number one cause of personal bankruptcy, people unable to afford healthcare. All real earning dollars are gone because they've been consumed by healthcare. Seniors, filing bankruptcy at the highest level ever, 85-year-olds. And the reason is healthcare costs. And so you begin to go through the whole list, and people are making choices in life. Do I feed my dog? Do I feed myself? Do I pay the rent? Do I pay my medical bill? And just this whole list of my prescriptions. I can't fill my prescriptions. And so yet, when we look at our issues, it's these impacts that sometimes that we are missing. So a decade ago, we, like a lot of organizations, always did community needs assessments, even before the Affordable Care Act. I'm not a fan, personally. I think they're like random acts of kindness. You kind of do a little this and a little that. And for us, we'd do one, we'd tell the board, and then invariably, toward the last quarter of the year, we'd pull it out and say, well, how did we do? And then we try to explain kind of how we did. And so, well, about a decade ago, we were looking at obesity things, and our board said, we really need to do something in obesity. So we hired a company to create learning maps, and these learning maps actually would fill your whole table. And our board had a foundation, so they gave us actually $500,000. We hired trainers. We built maps for preschoolers, early elementary, middle school, high school. And so for months, we hired a whole bunch of trainers. They went out in the schools. They went out in the summer and did training. So this goes on for a while, and then finally we get a call and said, we'd like to talk to you about what we're seeing. So that's great. So we're going to hear this really nice report about all the great things we're doing to teach kids how to eat healthy. And the trainers came back and said, well, we have a problem. These kids are hungry. And it's like, what? These kids are hungry. We can't teach them about nutrition because they don't have food. And it's like, no. It's not what we signed up for. Hunger, we can't do anything about hunger. So after months of thinking through this, we started going to all the hunger organizations. We started with the USDA, Department of Agriculture, Feeding America, Share Our Strength, the Alliance to End Health, Bread for the World. I'm probably missing some. And each time we talked to them, a lot of these organizations said, we've never talked to healthcare people before. Never. And what the heck you doing here? And then after about a half hour of talking, they go, where have you people been? Hunger is a major health issue in our country. And we look at hunger as an issue. We make it a welfare issue, and people debate welfare. There's nothing more boots on the ground than food. So you think about starting out with a healthy mom and a healthy baby, go back to the zip code discussion. 13% of households are food insecure. 19% are food insecure with families. Over 30% of single moms and kids are food insecure. That means, for a family of four, single mom, they miss 100 meals a month. And again, think about not only missing the meals, but also healthy meals, and the meals that you can do, especially after you look at SNAP benefits. So we lobby for SNAP. And when the first times we came in, our senators would go like, why are you here lobbying for SNAP? And it's like, because it's critically important to families. And I'll tell you, doing the right thing, then at the end they would say, well, what can we do for you? And it's like, pass SNAP. We gotta make sure SNAP is taken care of. And really, it's created a whole different dialogue. Over 30% of our seniors in this country, and we can talk about the aging of America, that's a huge issue, especially when you think about bankruptcies, on the issues we have with seniors. People coming out of prison, you read stats as high as 90% are food insecure. So if they don't have food, what happens? You can kind of, think about what happens in life there. And really the issue is the impacts of health, of hunger on health is just tremendous. And it's just logical. Healthy moms, healthy babies. Babies not getting the right nutrition day one. So whether you want to think about developmental issues, asthma, chronic diseases, suicide, risk for hypertension, the whole list goes on. And yet in healthcare, the way our system has evolved, we don't ask people if they have food. Now, it's changing. But you ask doctors, like, well, we treat people clinically, And the kind of way the system has evolved, that's not our issue. And so we became very, very passionate about hunger as a health issue, the cost of hunger as a health issue in our country. And so as we talked to more people, people like the AARP, CDC, and others, we really kind of, and now we talk about it a lot, is social determinants of health. 3 years ago, if you went to a conference and asked people, do you do social determinants of health? Nobody raised their hand. If I asked you today, everybody would raise their hand. So, oh yeah, absolutely, we're doing it. It's a little bit like population health. We don't know what it is, but we're doing it. And we sponsor a farmer's market, or we do this, or we do that. And really, it's this issue in life. So you begin to look at it, and for those of you that aren't particularly in healthcare, we're spending $3 trillion on that bottom 20% as a country. So why couldn't we use some of that money and apply some of it to social determinants of health? That's kind of our drive here, that some of that money should be, if you ask what would we like, we would love to see Medicare require complete screening of social determinants and that they pay us for it. And because actually as a country, we spend the right amount of money. Healthcare is the amount we spend. We just spend it all on healthcare. And other European countries spend more of that money on social conditions and social issues in life. And so you can start to break it out. And so every community is different. So you talked this morning about behavioral health and homelessness, which are huge issues, especially as you think about the home issues in your area. But for different parts of the country, these are very different issues. And I'll put in a plug for this Democracy Collaborative Anchor Institutions. So there's a lot of people doing great work in pockets, and people that have been doing it a while, and we can talk a little bit about where the economics of that will come for that. But the idea here, again, is we ask the wrong questions. Story after story, as people have come in for screening, our doctors would tell you, very skeptical at first, but all it took is one or two people to be screened that they didn't expect. A good example right out of the box, a group of physicians, they had a retired partner, showed up, suit and tie, came for his annual physical. They do the screening. He screens positive for food insecurity. They're a former partner. And of course, you can imagine their reactions like, what the heck is going on in your life? And again, bad investments, did some things he shouldn't have. He was food insecure. They would have had no idea. We've had stories of domestic violence, things that people didn't know unless they asked the questions. So the point here in healthcare is the way the system has evolved. And it's not anybody's problem. I mean, it's not like we did anything wrong. It's just that's the way the system evolved. Very clinically focused, and we just didn't do it. And it kind of defies common sense in some ways. Why wouldn't we ask all these health and well-being issues in people's lives? We just haven't. We just didn't, and that's really the system and how we evolved. And again, I go around the country, and we've talked about this a lot, and you still hear from people, not doing it. I don't get paid for it, not doing it. Not my job, not what I signed up for. I hear that from physicians as well. That's not what I do. I treat people clinically. Or I was on a panel recently and somebody was saying, all I care about is the next drug and the next research dollars. This is something that really doesn't mean much to me. A researcher was talking about that. And again, it's just like we ask all these questions where it's not my job. Aren't we boiling the ocean? We hear that sometimes. Do we have the resources to do all this? What if they screen positive? Then what? That's exactly it. We say that to our people all the time. Well, if they screen positive, then we're going to figure something out. And so we hear that a lot. And so the idea here is to flip the model. And the idea is to flip it from a pure clinical model. And it's not to say not to do clinical work. I mean, our jobs in healthcare is very, very simple. Keep me safe, heal me, be nice to me, in that order. And so don't misunderstand. I work for a health system. Our job is to do that. Now, the other part of the job is to begin to think of the social determinants of health. So beginning a decade ago, we began to screen for food insecurity. And we started out and said, we're screening all our patients for food insecurity. And you can see the numbers here from 17. So last year, we screened over 500,000 patients for food insecurity. If they screen positive, there's 2 questions you can ask, scientifically proven. We actually built those questions. I have a slide on it. We actually built them in Epic, if you're in an Epic shop. You can ask these quickly. We don't ask caregivers, the physicians, to do that, but they get the information, and we built out an intervention to be able to do that. So on the spot, if people are hungry, we give them a box of food. And the box of food, the food is paid for by our employees through a foundation drive. The boxes are assembled by one of our vendors. The vendor pays for the boxes, they stuff the boxes, they deliver the boxes as a mission thing. So when people go, what does that cost you? It costs us zero. So we do that. We started 2 food pharmacies. We have a 3rd one coming, where doctors write prescriptions to patients to go see a dietitian in a food pharmacy. How many of you have food pharmacies? Do you have food pharmacies? I want to talk a little bit about where the funding, a lot of this is philanthropically based. So a food pharmacy, and the difference there is, especially with elderly, they're embarrassed, they may not want to go get help, you know, I don't want to do that, I don't know where to go, I may not have transportation. When a physician says, you need to go down and talk to the dietitian and have a consult with a food pharmacist, they do it. And so it doesn't say food pharmacy on the door, it's the door with a number, they walk in, and literally it's a market with a table in the middle, and the dietitian sits down, and we can talk to you more about how they do this. They would look at your condition, they would look at your budget, and they would start to talk to you about, okay, this is what you have, this is what you should eat, here are some recipes that would meet your budget, and these are some things you can do. So it's this constant thing that, you know, you just kind of work with people. So we have food bags. We also found out, because just the nature of our organization, is we have people who live below the federal poverty line. You know, if you have a single person with a family getting minimum wage, they're living below the federal poverty line. So we had it with even with our own employees that they were hungry. So we provide food bags for them. Nondescript food bags. We don't screen them. We don't ask for their W-2. They want food, we give them food, and they can pick that up. Meals and discharges, we have a food reclamation program where we have people that go in at night into food venues and they reclaim food. Food that's been prepared but not served. And so we have part-time food packers that go into casinos and sporting venues, and they take food that would otherwise be destroyed. They repackage it, put it in freezers, and then we have someone that runs a laundry. As they're making their runs, they pick them up for us, and they deliver them to the food banks. We have a summer feeding program. If you're not familiar with summer feeding programs through the USDA, your hospitals can become summer feeding, paid by the USDA if you've never looked at that. And then we also started an inner city grocery store. So we mapped our communities for food deserts. So if you know the concept of food deserts, if you live in a food desert, again, think about it. So you would get in your car and you would drive to a supermarket. If you live in a food desert and you don't have means, you're not mobile for one thing. You don't know anybody that has a car. You can't even navigate getting on a bus, you may not be able to do it. You can't get groceries. And so we see that a lot, and especially this term came out of Chicago. People would go down to the corner store and that serves nuts and beer potato chip, what do you call those beer potato chip things? Pork rinds and all that kind of crap, and that's the only place they could do food. And really, all this evidence shows, again, that if you're not getting good food in your neighborhoods, it's really impacting your health. So we screened, or looked at our communities for food deserts. We found a food desert. We went to every grocery store and said, help us build a grocery store in this one region that we wanted to start in, and everyone declined. One of the grocers said, somebody's going to get killed in that neighborhood. We're not going to work with you. And it's like, all right, so we got in the grocery business, didn't have any idea what we're doing, but we break even today. And so we have an inner city grocery store, and I'll talk a little bit about that in a minute. These are the screening questions, 2 screening questions. They ask a little bit about food insecurity. Very easy to do. You can either do it on paper, you can put it on iPads, you can kind of have staff do it. And the thing is, all the physician get is the idea that they screen for food insecurity, there was an intervention done, and a follow-up was done. And if they want to talk about it and work with people, it works out really well. So here's what happened with our food pharmacies. We have an insurance company, and if you look at per member per month, these are people who went to the food pharmacy and those that didn't. There was about a 15% reduction in cost. Just that one social determinant episode. One episode, 15% left, just sitting down and talking about food. So if you think of that from social determinants, what if we could, go through and do a lot of research in this country and begin to figure out those, because those are really what's going to drive down healthcare costs in our country. At least that's our belief, and we're trying to prove that right now. So, we're now screening. We screen patients. We're screening our employees. And our idea, working with payers, the idea here, ultimately, and the holy grail here, is that every employer in the United States would screen for 10 social determinants. Your employees would be happier, healthier, better retention, less turnover, interventions in their life. And oh, by the way, what if it saved you healthcare costs? And so we're starting to work with a couple large employers today about doing screening. So the gentleman down on the right just passed away, Russell Ebide, president of Guardian Glass up in Detroit, very large glass manufacturer. That building is called the Ebide Market on the Green. That's our grocery store. You can see one of the young ladies sitting next to him was homeless shortly before that and working in the grocery store. So the first floor is a grocery. Mr. Ebide gave us $3 million. That was an empty building given to us by the city. He gave us $3 million to do that grocery store. So we got in the grocery business. The second floor is a training center and a financial opportunity center. I'll talk about that in a little bit. So we train employees to get kind of entry-level jobs in our system, especially things like nurses' aides and other aides and those type of things. The third floor is actually one of our board members actually moved a company in there to employ people from the neighborhood. So the financial opportunity coaches are probably one of the most critical things. It's helping people kind of navigate their lives. So one of the things that we do in screening is we ask people if they're motivated to change their life. And somewhere between 70 and 80% of people say yes. Some people refuse to be screened. So the idea here, again, is that, well, they don't, this is, you can hear this, people saying this, oh, they don't want to change their lives. Oh, those people this, those people that. And really what we find is people are highly, highly motivated to change their lives. They just don't know how. And so we think we provide resources, we think people know these things, and they don't. So this financial opportunity is the KC Foundation model. It's kind of a well-established benchmarking way. So we provide financial opportunity coaches for people that screen with financial issues. So they may not have a bank account. They may have a poor credit score. They may have filed bankruptcy. They may be in a position where their house is going to be foreclosed. They may be a victim of predatory lending. So our financial opportunity counselors work with them out of the Ebide market, and now they're also working with our own employees, because sometimes we don't know if they get in those situations. And the beauty is, it's paid for by a foundation, HASDIC, which I'll talk about in a bit, and our United Way. So it doesn't cost us any money, but we provide the screening in this neighborhood that we're doing. So two things as you start thinking about this. CRA, Community Reinvestment Act. How many of you know about CRA money? A couple of you do. You should all know about CRA. You should talk to your banks about CRA money. They need to make investments per the CRA, per that act, in your communities. And when you sit down and work with them, they have money to help. LISC is the Local Initiative Support Corporation. It is a CDFI, Community Development Financing Institution. I'm sure, I don't know if LISC is active here. They're based out in New York. But CDFIs, there are CDFIs. I didn't look it up, but I'm sure there are CDFIs in your area. You need to sit down with them. And so I'll talk a little bit about what LISC has done and some of the things they're doing across the United States to work with healthcare. And they love healthcare as far as partners. So this is the company, Credit Adjustments. They actually, they're a large collections company. We actually own part of this company. We don't like to tell people we're in the collections business. The reason we did it is so they could expand. And so they're about job creation, very kind of mission-based, run company. And so on the third floor of that market, they have 58 jobs, call center jobs, $14, $15 a month with benefits. And then if they work there, they can get assistance to go back to school. So again, it's the idea here that one of the best things you can do for people is to give them a job. So they do student loan collections and they do healthcare collections. So again, that board member, again, we had this building, the training center came in, then the board member came in and said, hey, I'll start putting jobs in this neighborhood, and worked out particularly well. And I'll talk a little bit about anchor institution local hiring. So this whole idea of anchor institutions and making these investments in your community is all this idea of being anchored in place. So anchor institutions, it's kind of a California thing, right? You guys know that, those terms. So the idea there is, again, anchored in place and really kind of focusing on local development and local job creation. One of my goals, my personal goals that I'm evaluated on, is job creation in communities, non-healthcare. So our board is saying that we need to create, I need to create a certain number of jobs in order to meet my incentives and everything. So Mr. Ebide went a little step further. So Jeffrey Canada in New York did the Harlem Kids Zone, where he took a geography in Harlem and said, we're going to do an intensive work in these neighborhoods. And so we took a page from that, and so in a very specific low-income neighborhood, 43604 actually, the zip code that we talked about, Mr. Ebeid gave us almost $30 million to invest in that neighborhood. So this is the part I would have never guessed, is the philanthropic support that people came forward with. Last week, one of our board members and their family gave us a significant amount of money for our food work, because they wanted to show their children the importance of providing food for others. And so we just continue to get community support from banks and others, because again, the banks have to do community work as well. Yesterday, a bank gave us $500,000 to do some work in this neighborhood. And again, you can kind of start to see here, again, just this whole model. And it's a high poverty area. It's an area that we think can be turned relatively easy. It's not the poorest neighborhood. But our work is in that neighborhood. So if you live outside of that, we're not working a block over. That's exactly the neighborhood. We get criticized for that, but that's the Jeffrey Canada model. You can spread your money over a large geography. So we're doing this intensive work in this area. And you can kind of see some of the statistics for that area and what's going on. So Mr. Ebeid's gift, so he gave us almost $30 million. Our system kicked in 10. And then the banks and others have kicked in another 10. So we have about a $50 million opportunity here to invest this in the neighborhood. So we're in the process of hiring 27 FTEs. So again, now we start thinking about kind of what you talked about today, and even how difficult it is to address these lives, so these issues in people's lives. It's intense work. It's easy to give people a pill. It's easy to give them a treatment. This is just long-term, decade work that really communities need to do. And again, you can kind of see the mix of people that we're working with, and we're trying to do research to try to figure out which interventions matter. A lot of work done on resident education. What we've learned is, especially from a health system standpoint, not everybody likes us. And so we show up and we're kind of cocky, and you know, they look at us like this big gorilla. Now we show up and we know everything, even though people have been in this space for decades working hard. And we've learned, you know, to be more of a participant. At times we lead, at times we support, at times we get the heck out of the way. And we've learned a lot. And again, a lot of neighborhoods have had a lot of people try to help over the years, and we hear it all the time. Been here, done this, what's different this time? And so really, I think that whole learning episode is what happens as well. So we have specific metrics on housing and health, jobs, income, education, and safety that we're trying to create in that neighborhood. Right now, we're working with a couple banks. There are nonprofit housing groups. There are also for-profit housing groups that kind of like this sort of space. So actually, across from that market, we're working with several to build housing, market rate housing, because we have enough low-income housing. We need some market rate housing in order to kind of create that next step up in the community. So we've got these metrics, and we're kind of on hook with the family to go back and produce those metrics. So LISC then, after Mr. Ebeid gave us the money, LISC comes in and says, we're going to match that. So LISC says, so you got to be careful with these organizations. It really wasn't a match. But what they said is, we're going to put in a $25 million loan pool for economic development. This is LISC money, not ours. Now, we did kick in some money, and this is money that is used to advance people's lives. It's being able to invest in women and minority-owned businesses in particular, but the idea is to help people start businesses. And so we have a loan pool. This is a loan pool, and we have a committee, and we give money out. We give money to people who banks would never touch. The goal is for people to take the money, build a business, and ultimately get a bank loan. That's success, if we can help them get a bank loan someday. So we make investments. Actually, the first dollar risk is LISC, not our system. So when we think about that, and really, as you start to look at it, you know, who is eligible, how do they apply, you know, what we kind of, you know, how we look at it. So we're probably the first partner of LISC in the country. But if you ask these CDFIs, they're all interested in doing this. This is the kind of work that they do. And a lot of them have tremendous opportunities. And you can kind of see here, and again, I think it's in your slide deck about kind of how it works. And if you'd ever want to hear more, I could get you some more details on that as well. So now we went from the hunger screening to now screening for 10 social determinants. And we're just trying to figure this out. It gets a lot harder. Hunger, we started with hunger. And the reason we started with hunger was because of the obesity thing. It was the perfect place for us to start because it's very tangible. I'd like to say we had this all thought out, but we just did it at the right time because you can give food to somebody and people can see it and they can respond to it. So that's a lot of times people ask, well, where do you start? You know, and from our experience, they start with hunger. Or start with, you know, homelessness gets harder. I mean, we talk about homelessness. That's hard. There's a lot of factors. You know, we have a real homeless problem in some of our schools. So our board members say, well, let's go buy a bunch of houses. Well, it's not that easy. You know, that's not the issue sometimes. And so, you know, the thing that's happened here is, so as we screen for the hunger piece and now the social determinant piece is beginning to build out kind of how you follow up on these issues. So financial opportunity coaching is pretty easy. It's got a model, we got coaches. We can do that online. We can do that on a phone. We can do that remotely. Domestic violence, much harder issue. You know, you start to look at, you know, some of the financial predatory lending thing, it's a little harder. So the idea that we have here is that we want to screen all our patients for the 10 social determinants. And then we want to begin to screen our own employees. And we're starting to do that right now. And we have 2 large companies. One gentleman owned a factory, and he goes like, I'll screen now. Let's screen my employees because they have issues. And even if you don't have it all perfect, we're going to start screening now. And our theory there is that ultimately it's going to you know, help us reduce costs. But here's the thing. So once we started with food, we kept moving along in some of these social issues. And the whole idea here is health and well-being. And the health and well-being aspects here is, again, it's just the things that we don't do clinically. So again, we could look at the screenings that we're doing. It's what we're finding. We're finding motivated people. Financial, behavioral health, food are the top 3 areas that we're seeing. What is very, very interesting, there's 2 other pieces that are now coming out, is the predictive modeling. So there are companies, we work with a company called Socially Determined. They can give you a profile of people at risk. For example, if you've ever been foreclosed on, if you've ever been evicted, there are certain risk factors. So now we can actually start to even do some predictive analytics. Not that that's a total thing, but we can add that now in a social determinant screening. And then the other piece ultimately will be genetic testing, but we won't get into that today. So we're doing a ton of research. We've had a number of research conferences. So along the way, we formed a national organization with AARP. It's called the Root Cause Coalition. We just had our national meeting in New Orleans. We had 600 people. We're going to be in San Diego, actually, next year. This is presentations from across the United States and all the different social determinants of health. You'll have people talk about hunger and domestic violence and housing and a whole variety of areas. So if you have an interest, if you go to the Root Cause, we have about 40 national members. We're doing some research there as well. And it's really a convening of folks to really do the things that we see up there. It's really about research, it's about advocacy and education. So if you want to put that. We spend all in about $8 million in social determinants. Now, most of that's philanthropic. So we spend about $873,000 now in social determinants. We didn't start there. We kind of built it up. Our board is 100% supportive. Our doctors are doctors, 70% supportive. Our employers, our employees, you know, they're supportive, but then it's like, can't you just give me a raise instead? Or can't you do this instead? So it's, and then you have turnover. So employees are a little bit harder, but we constant. So we've had this map, and it's just been this transition that we started with hunger. It's kind of moved to the other social determinants. It's moved into a lot of these other health and well-being aspects. But what's interesting about this is what's the message that sends to people, the support that we've gotten from places that we would have never expected. And it was just kind of like healthcare finally showing up and participating in these discussions. And I think that's kind of the bottom line. Anchor institutions I talked about. We've made a lot of investments in our communities. We have done some crazy things as a health system. We have bought a hotel, we bought land, we bought shopping centers, and we use our money, our balance sheet. So we bought a hotel out of bankruptcy. We flipped it to a developer from Chicago, and our only goal was to get our money back. And so we've been using our balance sheet. This sometimes freaks out trustees a little bit. We're making investments like that, and again, we're foregoing interest, but we're doing a lot of things. And this is actually our strategic plan. And it shows, again, most strategic plans aren't strategy, but we have a couple major strategies. Operational issues on the left. And if you see on the right, there are 3 things that we're committed to. Social determinants of health. We recently purchased a very large senior company. So we believe the next piece is healthcare at home. So we have a lot of efforts thinking about how we're going to deliver healthcare at home in the future. And then over the right, research education. And again, so the idea here is this health and well-being. It's really looking at a much more comprehensive model. It's really taking the things that we talked about today and doing those in a different fashion. So for us, you begin to look at the things about kind of the sort of things that we've been looking at. And really what the bottom line is over on the right is stronger communities. You're here, you're community people, you're working together. You're here trying to make sure you can do the right things to the community. And really, it's, again, where we started with Jim Collins. We all have resources. We can make impact relative to our resources. This is hard work for one person to do, and the way you do it collectively is for people to work together. So that's our story. Thank you for the opportunity to join you today.